It's a magic hour of 5 o'clock. We'll call Health and Human Services Board meeting to order. Roll call.
Julie Medeiros.
Present.
Lisa Lind.
Present.
Sean Anderson.
Present.
Kathy Leaf. Present. Dave Osnes. Present. Greg Telejohn.
Present.
Mike Barkalow.
Present.
Deb Lindeman. She's excused.
Next is approval of the minutes from Wednesday, June 15th, 2022. So, is there a motion to approve the minutes?
I move to approve the minutes of the previous meeting.
Second?
I'll second that.
Mike? All in favor say aye.
Aye.
Opposed, same sign? Or no, nay? Minutes pass. We have time for public comment at this point. I have Carol Ivance who would like to speak. Carol?
Is this on? Okay. Hi, my name's Carol Ivance. I live in Hudson. I'm a retired RN with over 30 years of professional and personal experience in the sick care industry. Not surprisingly, the global greedy elites are pushing yet another of the endless COVID variants to force the world to rebreathe our own exhaust by putting dirty rags on our faces, which have been proved in numerous studies to be harmful, especially to children. The former St. Croix County HHS board was sickeningly complicit with the power-hungry criminals and refused to pay any attention to us, the citizens. So before they try to force this new plan scare on us, we want to build a cooperative relationship with our new board. We hope and expect that you will change direction, even though you have the challenge of working with some of the same unethical experts who might continue to ignore reality and true science. We continue to request common sense measures and for actual health and safety to be your top priority. At the very least, we expect and encourage you to start recommending basic healthy remedies, not only to prevent COVID, but all diseases. COVID is a relatively harmless thing until it's weaponized in the hands of Mengelé's protégés. The clot shot is what's causing the huge majority of deaths, not to mention disability and illnesses. Just check VAERS if you don't believe me. Our immune systems are our best defense, provided we give them the tools they need. Fear tanks the immune system, so no more scare tactics, deceptive, fake test results, and so forth. Please teach the public about their need for zinc, magnesium, vitamin C and D, and to stay away from refined sugar, to name a few simple healthy practices. And we're still open to working with you on this. We will not consent to any criminal, unconstitutional, and therefore unlawful mandates, and we're very much hoping that we can start fresh and all truly work towards the good of all of our citizens. Thank you.
Thank you, Carol. Any other public comments? Any other public comments? That'll conclude our public comments. Thank you. Business items. First one is Health and Human Services monthly financials.
Good evening. So financials in your packet. Basically, I'm just going to kind of touch on some of the June of 22 to prior year June. Our revenues are ahead by $390,000. Part of that is tax levy, but we also had some significant increases in our CCS program and also in our Children's Long-Term Support Program that contributed to being ahead where we were at last time this year. For our employee expenses, the staff pretty much is exact or very similar to where they were last year, or at this time, just a little behind, and our operating expenses are below where we were at last time. The the decrease from our behavioral health unit and purchase services, we've had less inpatient stays, which helped to bring that purchase services down for that department. There's really, I think, in ADRC, if we skip to page 20, what I'm noticing is we are seeing an increase in catered food and unprepared food. We're going to expect that to keep going up as inflation is going up. We do have additional funds in ADRC that will cover that this year, and then we're working on budgeting for next year to cover that. Some of the other areas we have seen, especially on the nursing home side, fuel surcharges that are coming through now for some of our x-rays and transportation. So we will continue to monitor those pieces. When we get to page 24, we're looking at the healthcare campus. Their revenues are ahead of where they were at this time last year. Their admissions have increased in both Orchard View and the nursing home. We also have seen their actual salary and fringes decrease as we have reduced some of the restrictions. Staff are able to provide more services to groups of people rather than individually. We have been using some pool staff there, so that's an expense that we did not see at this time last year. But they are working on getting people hired to keep that in staffing increased. So overall, you can see on page 26, healthcare campus is at a positive. Both Orchard View and the nursing home are currently positive. So that's really all I had for highlights. Any questions on the financials?
I have one question.
Go ahead.
I believe the catered meals is because we changed the service at one of the nutrition sites, correct? I believe that's right.
Even that
Even
just
before?
happened, so this is already increasing
Before that?
prior
Okay.
to that change.
Okay, thanks.
Yeah.
Any other questions? Go ahead, Dave.
This one's probably for Bob. We are still adding more residents now. We've added staff, so we're allowed to bring more staff on, or residents in. Is that correct? And we're into Blueberry finally. We're opening part of that wing up. Is that correct?
Yep. Yeah. So all 3 wings at the healthcare campus are open. They are accepting admissions on a daily basis.
And with the hospitals releasing some of the folks to come in for outpatient therapy and everything else, that's helped us out immensely too on our revenues. Is that correct?
Correct, right. So the short-term rehab patients, I mean, it's really our Medicare residents that drive that revenue. So we are seeing the increase in Medicare days, so short-term placements for hip replacements, knee replacements, that kind of had all been stopped during the, COVID, those operations. So that has increased. And then I would say Orchard View, their census has steadily increased too.
Any other questions? Go ahead, Mike.
What is the operating capacity of these 3 wings, and where are we at for residents?
So 50 is what the healthcare or the nursing home has for residents. There's 14 and 7, so we're at 35 today for the nursing home. Again, it's kind of that so many CNAs to so many residents, so we have to increase them at the same capacity, and then we use pool staff to help cover those gaps. So as we need staff to cover those increase in admissions, the Bluebird basically is the wing that Dave had just mentioned. That's really where our short-term residents come in. They kind of that rehab unit, where the other 2 wings are, I think there's 1 opening or 2 openings in each of those, so they're basically full. Seats 19, so 48 at Orchard View, and I think they're at 79%. I don't remember the exact number. I didn't look at that today.
Any other questions? Thank you.
You're welcome.
Next is the update on American Rescue Plan Act initiatives. And Bob, I think that's you.
Yeah, thank you, Mr. Chair. Now that we've had a chance to implement some of these Arpa initiatives that were approved by the board last year and had some time to see what the impact might be on our communities, I've asked Char Lopez, our behavioral health administrator and operations manager, if she would come in and provide a little bit of early data on how those efforts are playing out and other other kind of summary information about the ARPA positions themselves.
Thank you. So I had prepared a document in there. I have a couple links because I have the actual American Rescue Plan Act in there. It's 243 pages if you wanted to read the whole document. And then there's also a fact sheet. And the fact sheet really drove how we could spend our monies. So I put a little bit of a timeline for those who weren't maybe part of the board at that time. So March of 2021 is when the American Rescue Plan Act was enacted. In that summer, we had proposed a few different options to try to hit some of those areas listed in the fact sheet of how we could really serve more of the clients that are underserved and the populations that are underserved. We were awarded some funding under that, and in late of 2021, we looked to publish requests for proposals, RFPs, to look for community-based partners to provide those services, and we would contract with them. And it was just as the employment, how there were the really hard moments of trying to hire people was happening. So there's a lot of reluctance from our community partners in engaging in that, as they felt they weren't going to be able to provide the service that if they entered into that contract. So we were able, so the majority of the positions ended up being limited term employees through the county. I was able to negotiate's not the right word, talk with and kind of reassure Northwest Passage, what is a long-term partner that we have, and they have provided peer support for us in other areas. And we talked with them in trying to just come up with a plan and how we could work together in trying to build this program under the ARPA funding. So the beginning of January, we hired 4 of the 5 limited term employees, really at a time where it was really hard to find employees, and we have 4 gems that we got, and we were just very lucky. It was some folks that are very passionate about this service area. And then we reposted for one of the positions, and we were able to hire another in, I think, April of this year. And then we were just the contract with Northwest Passage, they were just able to hire 2 peer support specialists. So as of the end of June, as of the last reporting quarter, we were able to have the 5 limited term employees and then the 2 additional contracted employees. Just a little review of the programming that we have. There's on that first page, I have listed the ARPA project name. We had to come up with a name that didn't necessarily fit with what we were going to do, but the name we picked we had to keep. And then we have a working title, and then we also I have the staff that are hired in there. So the Mobile Crisis Partnership, that's the programming that we have that we're working with law enforcement in the co-responder model. And this is probably, this area probably requires the most training and collaboration with different law enforcement agencies. So all of our law enforcement agencies have MOUs with us to be able to provide that service hand in hand with them. And we have 2 case managers, Brett Olmstead and Nate Cundiff. They're providing case manager crisis response right alongside law enforcement. Like I said, they do it with all the different jurisdictions that we have. All of the communication comes from the comm center, so it's clear and direct. There's no confusion. Law enforcement will call the comm center and they will dispatch them. They both have radios. They've both been trained. And it seems to be working pretty well. We meet regularly with the chiefs to get feedback, to see if there's other things we need to be doing. Very excited about this because this is actually one of the up-and-coming trendy crisis modes of providing service. There is funding down the road for some other different ways of providing this service, so it is something that perhaps in the future we may be able to tap into some other funding around this. So some of the things that we're looking at doing is providing what's called a soft uniform. So other jurisdictions have done this where they have like a St. Croix County emblem and then maybe co-responders. So when they're on scene or when they're in the community, others can easily recognize who they are and what their role is in the response. We're looking to do more community engagement with them. We have the National Night Out coming up, so they're going to be part of that. We have, we have 3 days a week while we have the co-responders are overlapping their hours. We provide 12 p.m. to 12 a.m. Service Monday through Thursday, and then we have 10 hours, 12 hours on each of the, or 10 hours on the other Monday and Friday. And so during those 3 days in the middle of the week, they're looking at having one being ride along, just so we have a little bit more community engagement, and not necessarily always in the crisis world, and maybe wanting to be a little bit more proactive in some things as well. So looking at the data that we have, so we did start this, well, we hired them in January. They're really the one was really ready to go in April. So some of the data we have from their first quarter is light because we only had one on, and with crisis there's a lot more training and that really training and supervision that goes along with it, because it's a lot of decision making in a very quick manner. So we had 33 crisis calls, and more than about 40% of them were the sheriff's office, about 18% with Somerset Police Department, and the average age was about 33, and the gender was really split between those identifying as male and female. So more to come in this. I can tell you probably within the last 15 days, we've probably had more than 33 calls. It's been a very busy, very, very busy. And I found we were doing just afternoon when we just had one person. He was working 3 to 11. With adding that earlier time, crisis doesn't, you don't schedule the crisis. And I can tell you the guy who comes on at noon is probably more busy than the one that comes on at 3. So it's just really hit and miss, depends on the day and what's happening in our community. So the second area that we have is the in-home on-site behavioral health case management. We refer to them as community case managers, and there's 2 of them, Emily Anderson and Christina Calguire. They're providing case management in areas targeting those that are typically underserved, and the population that we initially thought we were going to be serving were really just those in the homeless shelter, recovery housing, and releasing from jail. However, as we started this, there has been more of a need identified in some other areas. Just of note, local law enforcement has, so when they come on scene and something's not criminal and it's not a crisis, they don't often have what's the next step. So they've been able to call on these 2 case managers to respond on scene, or sometimes they send them just a referral if they've run into it and they say, hey, are you okay with me sending the report off to Human Services? Someone will be in contact, and then they can help coordinate some of the services and cares that folks need pre-crisis, pre-criminal. So it really has met a need that we didn't even know that was initially identified. So of note, we have 198 intervention contacts for that first reporting period from April to June. Average age of the recipient is 46 years of age, and part of this is because some of the population, again, that we didn't anticipate is a lot of our older population. So those folks who are over 60, over 70, homeless, without medical, without a lot of services, and not really knowing how to navigate to be able to find some of those resources. So we have that one staff who's working very closely. They both work with the homeless shelter, but one really works closely with the homeless shelter, one works really closely with the recovery housing, and found that there are a lot of folks that just need that, and it's a population that doesn't stereotypically, I think, accept resources readily. And so it's one that they're not necessarily asking for it. We're saying, hey, there's these resources, can we help you apply for them? So about 28% of the services coordination, they're really looking for behavioral health services with the county or with CCS, or behavioral health or mental health services or substance use services within the community. So that's the majority of the services that they're coordinating. And then second most requested is housing, which I think is to be expected with the populations that we're focusing on. And the service location is really anywhere that the client needs. So they're able to provide it in the recipient's home, the homeless shelter, the recovery housing, the hospital, the jail, the services center, or they've actually used the libraries at different places quite a bit. The libraries have been very open to allowing checking out rooms and for some confidentiality and things like that. They also have the internet available, so if they need to hop on the computers, they have the ability to go on and apply for services. The next one that we have is, we titled it as pre-treatment early intervention. We have a case manager who is located here at the government center, and she is the only Health and Human Services staff that is actually stationed here. So she becomes kind of the face of what we do. She works very closely with the Justice Department. So she works in conjunction. So those who come through jail generally have a connection to the justice services. So they're already connected to somebody who's monitoring their pre-release. So she's generally working with those who are not. So those who, a lot actually through child support, maybe through domestic violence court, anyone who kind of doesn't fall within the justice services piece. She's looking at, she does a lot of, well, actually her referrals do come directly from the court. She sits in the intake court each day, so they have the availability to, if somebody comes and says, you know, I'd like treatment, but I don't know how to do it, the judge can say, well, Cara in the back can help you go do that. And so she's right there, she'll take them and do it right there. And we found that that's a barrier. Having Health and Human Services be 30 miles away is a barrier for a lot of people. And so she can just do it right there. She can call, she can get it set up. That comes from the courts, the district attorney's office, public defender, the jail, law enforcement, or self-referral. And as a matter of fact, the majority, 37% of those who she's working with, of the contacts, come from folks just self-referring. Average age is about 37 years old, and she doesn't necessarily, her office is in child support because there's not a lot of extra room in the courthouse here, so they were gracious enough, Lisa was gracious enough to give her a place to sit, so that's where she is. The last one is that peer recovery specialist. Utilizing peer support is found to be incredibly effective with folks, but it's also very resource efficient. It's something that is written into so many different programs and something we've wanted, but we just haven't been able to get off the ground. It's a service that it really provides, we can provide something in a very, when I say resource, it's much more efficient to be able to provide peer support services. There were several barriers to getting this going, and I kind of touched on that. We really struggled to find a contractor that would provide this, and then our tough employment market was really, we still are struggling with that, but it was probably the hardest. It's a position that doesn't pay a lot, and so we had to negotiate with our contracted services to pay a little bit higher wage, so it's a living wage. Minnesota pays well, and Minnesota, they have a lot of programs available, so it's difficult to get in our area. Northwest Passage stepped up. They've been a long-term partner of us. so we were able to connect with them. Another barrier was just the timely training for the Wisconsin Peer Support Specialist training that's required. For whatever reason, St. Croix County isn't often included in their trainings. And all of their trainings are virtual now, so it makes it very easy to get trained. But a peer needs to apply first. And if they're selected, they are interviewed. And if they're selected from the interview, then they get the training. So it can be like a 4-month process to even get them into a training if they're accepted. That's if your county's included in that. So they were very gracious. They allowed us to get one of the peers into another county's training. And then, so she's actually training right now. We sent her to a different training that allows her to do peer recovery coaching, but we wanted her to have that Wisconsin certification so we could use her across all areas. And after, like I said, after a slow start, we now have 2 peer support specialists, Sophia Hansen and Dean Hollenbrook. Dean actually comes from central Wisconsin, but he had 9 years of experience working with the VAs as a VA peer, so very excited about his experience. He's able to just jump right in and help across all areas. So as of July 1st, we're accepting referrals, so I will have more to report next quarter on that. What questions do you have?
Go ahead, Mike.
So I'm just trying to wrap my head around all of this. So these are ARPA dollars that are going to go away.
Yep.
When?
Well, December 31st, 2024, or we have up to 2 years after that. If it isn't, we can spend, like if we didn't, like this one, we didn't get started till 6 months later, then we'd have, right? Am I saying that right?
Yeah, the county board allocated 3 years worth of funding.
Okay.
So through the end of '24.
Okay. So there's a multi-part question, so I apologize. So we've hired 7 people to handle these underserved people, and underserved meaning having unemployed, or what are we typically dealing with?
So part of this was it had to be tied to how did COVID affect this population. And it could be underemployed, it could be exacerbated mental health or substance use, but it had to be tied somehow to that. So the thought being when you're doing it is that you're going to help that area and then it should be better moving forward is kind of the gist of it.
So these managers, they're trying to bring them into using HHS as a kind of a leg up to, or a referral to a mental health facility, or what is kind of the, where do they go once they come in contact?
Yeah, that's a great question. Actually, anywhere. So it can be Health and Human Services, or it would be the community, or it would be Woodbury, or it would be Pierce County or Polk County, or wherever they want that service. Okay. Some folks working, well, in many of the programs within Health and Human Services create silos because of that's how the DHS rule says we can only work with this amount of these people that fit into this. This allows us to kind of work around that and not have to fall into that silo. So we have, just for example, there's a lot of folks that come to our homeless shelter that aren't St. Croix County residents. And under so many of our Health and Human Services programs, we can't service them. And with this, what they do is they connect them with Polk County or wherever their county is to get them back to where they want to be, or if they want to be in Minnesota, to help them connect with Washington County. Sure. So allow them a little bit more opportunities, because otherwise it's, we're just like, oh, sorry, we can't, because the administrative rule won't allow us to.
Okay. So I work for a nonprofit. Just this last winter, we had somebody that transient, homeless, had a RV that he was living out of in the middle of winter, and I'm like trying to get him in contact with certain county or homeless shelters, and he's like, they're all full.
Yeah.
And so I'm like, you know, we build homes and we try to help people, but at the same time, I didn't have a resource to point him towards, because
Right.
I don't think he was from here. I think he was from Colorado or Texas or something
Yep.
like that. So,
Yeah.
so what would be an avenue for that person?
Yeah, so that's a really good example where we have those two community case managers that if it's here that he's looking for services, they can help them here. If it's Colorado, they can just get on and figure out where he needs to connect to there, or wherever that he wants to be. Yeah, it becomes, there's so few barriers to providing that service to someone
Sure.
who isn't necessarily from here. And we get a lot of people, you know, we got 94 running through, so
Right.
we have a lot of folks that still need help, and they're still in our community. And the more we can help them become more self-sufficient and housing reliant, you know, and we can do that with these ARPA dollars.
Okay.
So,
All right, thanks, Char.
yes.
Any
Yeah, one sec. Okay, so looking at the yearly ARPA allotment that's listed here, we have a total of $700,000. You're saying that are we paying the cost of the program? Does this cover the salaries as well? Is this all inclusive, and we expect to do all of these things for $700,000?
Yes.
Or there's no more budget outside of that?
All of the expenses related to these positions are billed back to this. So yes, so each of those positions is about 100,000. It's a little bit less. And our next year's budget is a little bit less than that 200,000. So we were able to say we hired them at this amount, and this is what we need to put in there for next year's budget. So
this is the budget for their salaries. This is not the budget for the program.
their work is the program, really. They're the case managers, and they're out there, you know, we've been able to fund their trainings, and really that's about the cost that we have.
Okay, thank you.
Go ahead, Kathy.
I think this is great. Love the upstream tactics so that we don't get them in jail. So this is great. And the outcomes so far have been good. So thank you.
Thank you. I should say too that Ellie Clausen, I'm not a statistician. It's not where I shined in school. So Ellie, from here on out, will be helping we have a database that they're inputting all their information, which is great. I just need help reading that and making sense of it. So moving forward, there will be better outcomes, I promise.
Yeah, Ken, go ahead.
Yeah, the big picture on why the county board originally approved this was, it's all service delivery, so they don't get anything at the end, they're getting a service. So those are the costs, and it's all labor and benefit cost. These are avenues that aren't readily addressed through current funding sources, through grants or through normal administrative rules. So this is an experiment. And so we funded a 3-year experiment into these different areas. So what we're going to be looking for is these statistics to determine at the end of those 3 years which ones should continue on and be funded, and also to try to sell the state saying this is a really great program. All these counties are trying things along these lines. The state should create some grant funding sources for that. So that's how you should sort of frame it, of how we're looking at it, and the details that Shar provided is what you should be looking at as you make those determinations a few years from now.
One other thing so many of the things that we just saw as needs are really identified in many of the things that are occurring at the state level right now, which is exciting because things like peer recovery specialists, they're like, oh yeah, that should be a Medicaid benefit, and it isn't right now. So you have to be in a very specific program to be able to do that. The mobile partnership with law enforcement is another hot topic where they're really looking at how can we enhance this and how can we fund it better, because that's expensive to do 24/7. It's very staff intensive. And so that is very exciting to know that we're a little bit ahead of the curve, and if these funds do become available, when they become available, we'll already have a really solid plan, worked out all the bugs, and be able to move forward, and have the statistics to support it, so.
Any other questions? Go ahead, Dave.
Ken, we've only gone through the first half of ARPA funding, right? We've got another half coming, is that correct? The third half set, and we'll just double check it.
Yeah, well, it'll be on your August agenda.
Okay. But one way or another, we should be good with all the good stuff we're doing here.
Yeah, all of these were
All the way
fully
through
funded through the
2024, is
first
that
phase of ARPA projects. Yep, they're fully funded for the 3 years.
Thank you. Next item is presentation of proposed withdrawal management services. Again, Bob.
Yeah, thank you, Mr. Chair. And I just wanted to thank Shar for her work in helping to design and implement these crisis services. When we proposed these particular interventions to the board, the idea was to be planful and thoughtful about how can we intervene at an earlier stage in crisis to prevent people from going to hospitals, to prevent them from going to jail or cycling through those systems. So in actuality, when we get good and at this kind of work and when we expand upon it, we'll save costs and we'll have better outcomes for people because we'll be reaching them in the community. Speaking of underserved populations, it's not just people that we don't have statutory ability to serve, but it's people that aren't getting services for some reason that often end up in crisis. And our thought is to reach them in the community, intervene earlier, and help them stabilize so that they don't end up in these high-cost, poor outcome situations. And that's what they seem to be doing in these early stages of outcome measures. So we'll continue and refine and improve our efforts, but it leads into this discussion about withdrawal management. The board also approved, as a part of this ARPA funding, $150,000 to develop or support withdrawal management services. Hopefully you've had a chance to look in your packet and read some of the material I put in there. I tried to summarize everything in one page so it wasn't overwhelming, but I also added some detail just so you could look into it a little more closely and understand better what it is I'm talking about. But I'm happy to answer questions after I'm done with this piece of the agenda. But withdrawal management is essentially, it's a medical service to help people safely detoxify from any drug. And as defined in ASAM, or the American Society of Addiction Medicine, withdrawal management also provides mental health services, medical care, referral, and linkages to people or providers in the community. So it's not just you go in, you detoxify, you leave. It's you go in, there's treatment planning, there's medical care, there's behavioral health support that follows you after you leave with those linkages to community partners to provide ongoing support. It's a service that I've managed in the past. So I've been the director of a withdrawal management program in Ramsey County, and I was a consultant and manager for a program in Hennepin County, a 65-bed facility there. But we were able in Minnesota to develop this level of care as an alternative to hospitals, as an alternative to going to jail, at a much lower cost than hospitals or jail, for that matter, and providing a better quality of care, safe medical detoxification, and then ongoing support through peer support, care coordination, case management when people leave. This prevents people from cycling through the system, as I said, through jail, through courts, through hospital emergency departments. If people don't have insurance, they still get health care, but they go to emergency departments and they get it, and then we end up paying for it. It costs taxpayers dollars. So as we looked at this proposal, and we have been in discussions with DHS for the last year about the need for community-based withdrawal management services as an alternative to emergency hospitals or emergency departments. DHS warmed up to the idea of that's a good idea, and they put out an RFP for community-based withdrawal management that we're applying for right now. That RFP is due August 5th, so it isn't finished yet. Part of what you see in your board packet is an early draft of what I'm working on. But as we look at the bigger picture and we look at these ARPA positions that are already intended to prevent crisis, to address crisis in the community before it escalates, prevent people from going to jail and the hospital, this withdrawal management service fits into what Shar mentioned, which is a larger state strategy where they're calling it, I have to look what the name is, but it's the Crisis Now model that the state of Wisconsin is looking at. The Crisis Now model includes many of the things that we're already doing, so we're a bit ahead of the curve there. But one thing that's missing is these short-term crisis stabilization services that can be an alternative for law enforcement to drop people off at. We stabilize the person and then we refer them on or link them to ongoing care. It avoids people going to the emergency department, it avoids people going to jail, it saves law enforcement a tremendous amount of time because they can just drop someone off and not be obligated to stay there and wait for 8, 10, 24 hours, or transport them to distant facilities or around the whole state trying to find a bed. So there's a tremendous, I think, advantage for law enforcement, for emergency departments to relieve the burden on them, and certainly for the consumer who has a better outcome in the end because they actually get the treatment that they need for their addiction and or their mental health disorder. So that's the proposal that we're working on. Now, one key aspect of this effort being successful required all of the planets in the universe to align, and they sort of did. We have a provider willing to operate this service for us within the grant award amount, Kai-Shin Clinic, and we have a representative from Kai-Shin here tonight just to briefly walk through what Kai-Shin Clinic does. I've worked with them in Hennepin County on withdrawal management services. Dr. Sasaki is an impressive and motivated and passionate physician who very much wants to do something about the addiction crisis that we find ourselves in, and she isn't comfortable sitting back and waiting for action. So she said, look, we want to move into western Wisconsin. She knew me, so she reached out. I said, well, here's a grant opportunity that fits that very need, and can we work together? And we began having these planning discussions about how that might look and how it might work. We also started discussing this idea with Western Wisconsin Health. And Dr. Anwar, who is also here tonight, and Ailey Peterson, the hospital administrator, were very interested in the concept. And they started also participating in these planning sessions where how could the hospital, the Withdrawal Management Center, and the county partner to coordinate efforts and provide a continuum of care for people as they enter the withdrawal management service. They have severe withdrawal or some other medical need. They can be transported to the hospital to stabilize, come back to the Withdrawal Management Center, and then discharge into the community with support from the county. And we're receiving lots of, as a part of this planning effort, lots of positive input from Western Wisconsin Health and Kai-Shin on how we could make this work here in St. Croix County. This would be the first of its kind in Wisconsin, this community-based withdrawal management service. Now, the part that I need to have happen is I need to be able to use a facility that's not going to cost us much or anything. And it occurred that we have the Kitty Rhodes Memorial Memory Care Center at the nursing home campus that hasn't been utilized for the last couple of years or since I've been here, primarily because of COVID restrictions and then because of workforce challenges. So it's an empty facility right now, or separate kind of facility that's perfectly designed for this kind of service. So the thought occurred, could we use that facility to provide withdrawal management services and have Kai-Shin Clinic come in and operate them? That's where I need some support in moving a resolution forward to the administration committee suggesting that we repurpose Kitty Rhodes, at least temporarily for the life of this grant, for this purpose so we can operate this withdrawal management program. We also have to get the grant, so there's that, but I'm fairly confident that we will. So with all of those pieces sort of at least coming together to a certain extent, I thought it might be helpful to have you just briefly hear from some of the representatives of law enforcement. We have Chief Gordon Young from River Falls here and our sheriff here tonight, who could just provide, from their perspective, how would a service like this benefit law enforcement. And then I was going to ask Dr. Anwar from Western Wisconsin Health if he would come up and just briefly explain how the hospital sees this kind of service as a benefit. And then lastly, just a brief presentation from Amy Morgan from Kai-Shin Clinic, who's a business development director. And she could provide just a bit of information about Kai-Shin Clinic itself and answer questions about that. And then at the end of all this, I really would be open to answering any questions you have. I think I can answer them. If I can't, I will certainly get back to you. If that's okay with you, Mr. Chair. If I could, I would just like to ask Chief Gordon Young from River Falls and the sheriff to please come up and just provide their perspective on how this kind of a service would benefit law enforcement.
Thank you and good evening. You know, when this opportunity was proposed and reading through it, this opportunity would give us one more tool, one more resource locally that we could offer to residents in this county. In preparation for this my part anyway, I kind of looked through and I knew there was a gentleman in St. Croix County. And as I looked through the number of calls for substance abuse, alcohol, intoxicated, we've had 20 plus calls since April. He's either gone to the hospital, family members over, and a number of times he's looking for help, but there isn't anything local. And many times when we get out to these places, they've kind of separated from family that can't run them over into the cities when they do want help. I think the opportunity is going to be very beneficial if it can happen. Then I also then go to those that are in jail, just getting out of jail, that are looking for that detox, because the jail is not a detox. By the time they get to court, there's some that are just coming down, they get their bond or their bail, and out the door they go. And then what? We get called back, and it's the same cycle. So if we can somehow intervene with resources, I think this is a very good, again, I keep using opportunity because it is an opportunity. Shar went through a number of opportunities that we've been given in the last several months that have been very beneficial for us in law enforcement, diverting people from jail, keeping us, law enforcement, out on the street and not driving across the state. So I sure hope that this is an opportunity, again, that we can really look at and I hope make happen.
Good evening, Gordon Young from River Falls. First off, I'd like to say just compliment Bob and Shar. I think here in St. Croix, we're very fortunate to have them, especially with these ideas that they both come up with to help us. We're struggling in Wisconsin right now, especially towards mental health treatment, and even for those that have addictions. The closest facility for mental health is in Oshkosh, and for us, it's a 5-hour drive. And our officers spend approximately anywhere from 8 hours to even, we had some cases over 36 hours in the hospital prior to even going to a treatment facility. And if we do implement this project, it could be just an hour from the time we approach the patient to dropping them off, which is unbelievable. I'm very hopeful, and I have Bob's confidence. Him and I sit on several other committees together within the state, and even one recently with the Chief Justice of the Supreme Court here in Wisconsin. She wants to see a change. And just this week we had a meeting, and this is exactly what they want. This is what the state wants to go to. And for St. Croix County really to be the leaders of the state would be tremendous. And I just couldn't, I couldn't be happier if this does go forward, and hopefully we'll get your support. So thank you.
Is there any questions?
For both of you gentlemen, thank you for all your work. Where are the closest places right now? And I know, Chief, you mentioned Oshkosh. Where are the closest places that we'll end up taking folks right now?
For alcohol, it's going to be Chippewa Falls. And then there's only certain criteria for us to do that. You know, they have to be unable to care for themselves. But in many of these cases, they can care for themselves, and they don't meet that criteria. So the alcohol one is challenging for us at times. Mental health, you know, we talk about Eau Claire, limited beds, and then down to Oshkosh. Cumberland used to have a spot. Dakota County used to have for alcohol, but those have all gone away. So it's traveling.
And and I'm dating myself, but I know you've been around a while as well, though. But we used to take folks to Cumberland. Was that a totally different program than what we're looking at right now?
Yes. The one in Cumberland was the reason we now go to across the state. Cumberland was that local mental health crisis bed.
Well, I think this is a great opportunity, not only for us, but it's going to help you folks out. It's going to help the folks that really need the help out.
Well, it'll keep them local. It'll keep them around their families.
Well, I was just going to say that, and if we can keep it local, that's the biggest thing.
Absolutely.
And if to me, it's a no-brainer right now. Obviously it's a need. We've got a facility that we can start with. Bob, you can introduce our other two folks that are willing to help out with that one. We'd be foolish not to do this. And if we can lead the state on this and show folks that this is what it's all about, I think it's a good idea.
Thank you, Chair Telejohn and Supervisor Osnes. Thank you, Chief. Thank you, Sheriff, for taking the time to come tonight. Thank you, guys. Yeah. If I could just call up Dr. Anwar from Western Wisconsin Health. Thank you for coming, Doctor. I know you're busy, and you've prepared just a brief presentation. Thank you.
Thank you, Chair, Board, community members for having me. I'm Dr. Faisal Anwar. I'm from Western Wisconsin Health. I'm their Chief of Staff. I'm also a practicing hospitalist there. Bob, is it possible to have the one slide that I prepared just to show up? May make a good visual aid. But I can jump straight into this.
Yeah,
please.
thank you.
Thank you. So, okay, paper copies, that's totally fine too. And if you have any questions, please feel free to interrupt. I made this as brief as I could. As the police chief and sheriff were sharing, the hospital staff and hospitals in Wisconsin are struggling with this too. It has not elevated itself to a problem, but it is a very big need. And one of the biggest needs is that whenever there are patients either from alcohol abuse or any other kind of substance that presents to our emergency room, we have the immediate resources to take care of them in the emergency room and in inpatient if they're unstable, but we don't have the resources to help them fully recover or to break the cycle of abuse that caused them to come in the first place. One of the biggest benefits I see from this partnership is that serving the community is the biggest, Thank you. That's okay. I remember this from school. Perfect. Thank you. So as I was saying, serving community is the biggest tenet that I think would come from this partnership. Right now, substance use and alcohol use patients coming to our hospital, and I'm sure most hospitals in Western Wisconsin and beyond, they do not have a safe disposition after they immediately come to the ER. Sometimes they go to jail, and that's not the best use of resources or service to patients themselves or their families. They just get stuck in this cycle. And I'm at an embarrassment when I have to tell patients that, you know, you're stable now, it's time to find a facility, and we don't have any facilities here. We have social workers and a lot of staff looking for where patients' insurance would cover, and a lot of times they have to cross state lines and find piecemeal centers that may or may not take them. And ultimately, I sometimes see these patients again and again, and sometimes I don't, and I never really know what their follow-up is like. I don't see them again in my clinic. Sometimes we see them again in other hospitals, and it's just a very big disservice. The other biggest thing is cost effectiveness. At our hospital, in our emergency room, we have about 4 substance use patients that come per week. 2 of those are alcohol. This is on average. And just those 4 patients that come per week is costing our hospital and our emergency room about $450,000. So just based on those few numbers and that huge cost savings, I can see that cost savings passing on to our hospital and all our staff, saving all that money and instead going back to our community. It can also improve efficiency as well, too. It can help some patients that are otherwise stable go directly to a detox center instead of coming to the emergency room or being admitted when they don't need to. And there's lots of patients that come to the emergency room, they don't need to stay for long, but then the police either take them back once they've sober up or they are discharged from the ER and we don't really know what their disposition is. And finally, it can improve workflow. Right now, most of these patients, when I follow up with them with either phone calls or a visit afterwards, I can tell that they have not established care, one, because they never successfully completed the detox. So they're right back to the factors that led them to relapse in the first place. And so they don't have any good primary or psychiatric care, both the resources that we have at our own hospital. And they're not able to utilize this because they don't have substance use resources to put them in touch with this or to really use the resources that are available. So those are the biggest benefits I see from this partnership, and I welcome any questions that you may have.
Any questions?
Yeah, thank you, Bob. Or Greg, sorry, Greg. Have we explored renovating Kitty Roads yet to be able to facilitate this? Yeah, maybe we don't. Is it isolated enough where the population in the current Kitty Roads, which would be the detox center, is that isolated enough from other people?
Yes, Supervisor Barkle, I can answer that. I put in the board packet too. There's more information about how the facility is designed, but there would be really very little renovation that would need to take place to the facility. As I walked through it, it was almost perfectly designed for this kind of service. And it was initially designed for people, like I said, with dementia and behavioral conditions, so that the safety concerns and the environment itself was really already designed for serving a population similar to this. So the renovation or any kind of modifications to the facility would be minor, maybe some security cameras, maybe suicide resistant kinds of shower curtains and things of that nature. But other than that, we would use either the grant funding or ARPA funding to make those modifications. And the other question around access to other parts of the campus, no, there wouldn't be any. All doors would be locked, or any door would be locked that would have access to any other part of the campus. There would just be an entrance, an external entrance that would be used for people entering the facility, or law enforcement dropping people off. So there would just be one entrance and no access to the rest of the facility. I just would like to just quickly say, and thank you, Dr. Anwar, for the presentation, but just quickly say that there's sometimes a perception of these kinds of programs being chaotic or violent or full of behavioral problems, and it's really not the case in reality when they're operated properly. It's more like walking into a hospital and seeing patients in a hospital. It's usually very calm. The staff are quite adept at managing any behavioral issues or people that are intoxicated, so there really isn't this chaos or this image that people sometimes conjure up when they think of detoxification or withdrawal management. And again, thank you, Dr. Anwar, for taking the time to come tonight.
Thank you, Bob. Thank you, everyone.
Okay, Mr. Chair, and then I just would like to invite Amy Morgan to come up from Kaishin Clinic and just provide a brief presentation about what they do.
Thank you.
Good evening. Amy Morgan, Kaizen Clinics. Dr. Sasaki couldn't be here tonight, so her apologies are extended to you. I'm here just briefly to give you, kind of a general overview of Kaizen Clinics and, what we do and the good work that we're doing in the state of Minnesota. We are looking to open a detox facility in conjunction with St. Croix County. We're also looking in the state of Minnesota and Ramsey County. We've actually placed a bid to purchase a building to do the same type of thing we're talking about here. We offer medication-assisted treatment, medication management as they continue in their recovery, mental health assessments, and psychological testing. We have psychologists and psychiatrists on our as a part of our team. We have a CAP certified drug testing laboratory as well. So every client who's either in withdrawal management services, detox, or even as a continuum of care are drug tested each week just to monitor that they are taking their medications that they're supposed to be, and that, of course, if anything is in their system, we wouldn't continue to prescribe medications. Physician direct access, our physicians see all of the clients. We have an outpatient treatment center as well in St. Paul, and of course continue services as we go along. Oh, thank you. We treat all sorts or all forms of addiction, and so we can detox and provide medication-assisted treatment for all drugs. Of course, alcohol, opioids, and fentanyl, of course, are the big, the huge use that we're seeing these days. On the mental health side, anxiety disorders, PTSD, really the whole gamut of issues that we would see clients come through, we can assist them with. The detox facility, I understand, Bob has a very detailed packet, so there's probably a little repetition here. But we would be providing 24 hours a day, 365 days per year facility. I understand it's a 10-bed facility right now. We may look to expand that to 16 beds based on square footage licensing requirements, which of course we would prefer to do if we could. The more beds we could help, the better. Upon discharge of our detox facility, of course, the clients would continue to see Kaizen unless they, move to another provider. We are looking to open clinics in attachment to the detox facility. Really, this would be the first piece of it. And as we move along, we would open a clinic very close to the facility where clients could continue their care. Short term, we would probably see those clients via telemedicine after they are discharged from detox if they wanted to continue services with Kaizen. Once we see that we have some support from you and the county on this, we will quickly start credentialing for insurance providers here in the state and working on licensing. Dr. Sasaki probably could speak better about this, but she wanted to give you some sort of ideas about how we treat in a detox facility for what substances. And so if someone comes in for an alcohol detox, we would withdraw them typically with Valium to start. For methamphetamines, you treat with comfort medicines, and then psychosis will happen, and they treat that in accordance with how they show. Opiates are typically treated with Suboxone, which is the most, I would say, kind of gold standard medication used for detox and medication-assisted treatment as we move through. Could go to the next slide. So medication-assisted treatment really is medications used to help substance use disorder in conjunction typically with behavioral integrations. And so, of course, there would always be that support and recommendation that clients that are being treated at Kaizen for medication-assisted treatment are also seeking behavioral interventions as well, either in treatment, counseling, those types of things. MAT, MAT is for short. It really bridges the gap between as they detox, when they're stable in a detox facility, and when they leave and the cravings come back and the side effects happen. So medication-assisted management is really managing that. It's managing the cravings, the side effects, and all of those things that throw them back from recovery. We've seen exponential, excellent results. For those living with addiction, MAT has reduced the death rate by about half in our current stats that we find. And those who continue on MAT services through 2 years have a 90% sobriety rate. And so those that can start and stay with a MAT service, there's incredible success rates. Dr. Sasaki is our medical director and founder of Kaishin. Very accomplished. Again, she knows Bob from working at, I believe, Ramsey County Detox. Is that correct? Hennepin, thank you. She's a board-certified addiction physician. All of our physicians that are on staff are that as well. And that's all I have. Thank you.
Thank you, Amy. Thank you for coming. I would be happy to answer any questions. I'm sure there are some.
Go ahead, Mike.
Thank you, Chair. So I have a close friend, and this is actually might be a better question for Sheriff Knudsen, but she was a former jailer. She was in charge of doing the drug testing for repeat offenders, I think. I'm not exactly sure what was it? Thank you. How would this coordinate? Would this treatment center coordinate with that? Okay.
This service area would coordinate with any aspect of the community where there was an interface between that program, that service, and the withdrawal management service. So it's really an open door kind of for any opportunity that might exist between law enforcement or any other community provider and this service. The other thing, this doesn't speak to your point directly, but the other thing I didn't mention was, as a way of sustaining this effort, we could look to contract with other counties as well to purchase beds or use this service, at least a portion of the beds for their residents at a lower cost than what they're currently paying for the same benefits that we're realizing, but to make it a regional effort for law enforcement, for providers and other counties if they wanted to purchase beds from us. It would also assist us in sustaining the effort beyond the 2-year grant life.
Go ahead, Sean.
Yeah, I know that the state just recently funded, I think, the Chippewa Falls facility, or one in Burnett County. Well, how is that one just too specific as to what it can be used for?
I don't know what they funded it for. Do you have more information about that, or?
I just remember reading about or hearing that in the last budget that was passed, it involved a service or a local center that sounded similar to this in Burnett County.
I don't know.
I could be mistaken, but
I'd have to look at whatever that was. This would be a unique service area for the state of Wisconsin. This doesn't exist anywhere else right now. So whatever they may have received money related to detoxification, I don't know that. But this particular effort involves a more comprehensive approach to addiction and mental health through medical professionals and behavioral health professionals, with an emphasis on linkages to the community, peer support, care coordination, and those other things that oftentimes don't come with some of the existing options that are out there. So I would have to look at whatever that funding was to better answer that.
Go ahead, Chief.
There may, you may have read, the governor pledged $15 million for 36 beds, partial juvenile, partial adults, located in Eau Claire and Chippewa Falls area. And the last I heard is that they're about to sign a contract with the hospitals to expand the beds. But the issue with that is it's basically bringing Winnebago from 5 hours away to an hour and 15 away. It has nowhere near the same capabilities of what the proposal is here. We would still have to go to a hospital and get the patient treated, and then have the doctor at the receiving hospital in Eau Claire or Chippewa Falls approve the admission of that patient. And there's still even some discussion whether or not they can then deny the patient, and once again we would have to go to Winnebago. So it does help, but nowhere near what this proposal is.
Thank you. That was very helpful.
Thank you.
Any other questions?
Back to the facility. Being that it's in a nursing home and it's in close proximity, and I understand the lockdown features that it possesses. I worked in the hospital for 30 years. They used to overhead call, you know, somebody got out, those types of things that bring pause, putting it next to one of our most vulnerable populations just around the corner. To put it there, and you know, the doctor discussed the disposition and being unaware of, we can't forecast the disposition of somebody being withdrawing. You get what you get, and then you have somebody that's on that to throw the meds, to do whatever to bring them into a place where they're able to be calmed. But there's so many what ifs that are left open, putting them in the nursing home. And I understand that there's a huge need, huge, for this science to be able to be dealt with. But is that, and I understand the locked facility and it stands open and fiscally responsible. I get that. It can be a very dangerous population. And I think that we would have to get out in front of that too. They're not aged people that we're putting in there necessarily. They're anything from a young, virile 18-year-old, likely adult, not child, that would be put into this facility. Is there going to be an armed guard? Is there going to be a security desk? Is there going to be all of those things that the hospitals have to have? We have double locked doors there on their own floor because it can be a really crazy time. And I know we like to think, oh, we'll medicate them. It's all good in theory. But in practice, I mean, what's our threshold if that's not the case? I mean, if we push through and we implement this, do we just say, well, the first thing that happens that doesn't go well, do we pull the plug? Or is it the 10th one? Or, and I know none of us have the glass ball, but just my gut, sorry.
So walk me through the steps. So today would be passing this on to admin to prepare a resolution to go before the full board, correct? That's the desired outcome. But then if you were to get the grant, this would be part of the process to address some of the issues that Lisa brings up.
The resolution would be to repurpose the Kitty Roads facility. It wasn't intended for this population. So when the board approved Kitty Roads, it didn't approve it for people receiving this kind of care. So that would be the point of the resolution, correct? The other aspect that I'm looking for tonight is just gauging your support for this kind of effort to address addiction at this level of care, but also to build on the current structure of our crisis service system, which is fragmented, complicated, and difficult to navigate for everyone involved. So it's trying to improve that system of care. And if I could speak to Supervisor Lynn, as I said, I've operated these facilities in Ramsey County and in Hennepin County, 50 beds, medically monitored withdrawal management. And I can tell you when I started at Ramsey County, I came from out of state and I entered the Minnesota system of care where they have these withdrawal management centers where they were required to have them in every county or available to every county in Minnesota. And the county was responsible for payment of them. So it was a brand new facility that I entered into, but I found it was operated an awful lot or almost identically to a detention center. It was a locked facility. There was automatic tension. When you walked in there, you felt the danger from the staff and the clients. There was this contentious relationship, and it was like you described. So we changed the environment. We unlocked it. We changed our approach, and we gave people a choice. There was much more to it than that, but we created an environment that was welcoming. We included medical and behavioral health professionals much more in the mix of the multidisciplinary staff approach. And what we ended up, and there was similar concerns from the St. Paul Police Chief who I met with and a variety of hospitals and other providers who said, oh my God, if you unlock this place, it's going to unleash all of these people into the community and it's going to create all these crimes and problems. But we prepared before we unlocked it to create a different environment than we unlocked it, and it took away that tension almost immediately. Our incidence of violence went down to less than 1% of the patients admitted that created any sort of, it wasn't even violence, it was sometimes destruction of property because they fell into something or accidentally damaged something. Our incidence of people leaving against medical advice didn't go up. We went from having, a 92% reduction in seclusion room placements because people, when they're secluded, become more angry and upset and traumatized and re-traumatized, and it creates even more problems. So anyway, by changing the environment and our approach to working with this population, what we ended up with in Ramsey County and in Hennepin County was more of a hospital environment in the sense that when you walked into the environment, there wasn't that tension, there wasn't that anger or that frustration at being locked in a facility. And you had staff trained in trauma-informed care, trained in motivational interviewing, trained in how to approach people in situations like this. The reality is these are just people from all walks of life who are very sick. And the reason other counties and other programs don't develop these services is because they're afraid of that population and they anticipate these kinds of problems. But in reality, when they're run well, they don't exist. You always run the risk of something happening in any kind of crisis stabilization service. There is no way to reduce risk to zero. But I can tell you from my experience and from my research, from my work, that it doesn't have to be the case. You can operate a facility safely, quietly, calmly, and provide people with the help that they need so that they can go back to life again and contribute back to the community. And they really get back tenfold once they're in a recovery program. So that's my best answer.
I appreciate your experience. It still brings pause. And at what point will we talk about unlocking this unit?
It wouldn't be locked.
It wouldn't be locked?
No.
So it's a not locked unit that would be right there in the nursing home?
It would be separate from the nursing home. There wouldn't be any access to the nursing home.
They would build another wall? Because we visited the nursing home. It was right up that ramp from the nursing home. We didn't go through any door.
So Kitty Roads, yeah, there's a nice picture here of the Kitty Roads area. All the wings were designed the same. This wing is segregated, though. It has an internal access door to the hallway, which is locked with badge access only. That would remain. It has its own exterior entrance, and I think that's the entrance that Bob is referring to would not be a locked entrance. But the one into the internal would be badge access only. So you could exit the building, walk around, and come in a different door, though, to your point, yes.
Yes. And we are very clever when, when there's carbohydrates on the other side of the door. Thank you.
Do we require any action tonight?
I believe we need a vote to move a resolution to the Administration Committee to repurpose the Kitty Roads facility for this project.
So we need a motion to ask for a resolution to be prepared?
Correct, yep, yeah. Yep, so you'll be a recommendation or a request by the Administration Committee to take up the resolution. They're vested with uses of properties, so that would be the committee that would have jurisdiction to start it before it goes to the full county board.
I move to move this to the Administration Committee in the form of a resolution to repurpose Kitty Roads for a withdrawal management facility.
I'll second.
There's been a motion and second to ask for a resolution to allow the change to the Kitty Roads facility. Any other discussion?
I think the benefit is we have a huge need. I think this is a way for us to be pioneering in St. Croix County. If you look at our mission, it's innovation through cooperation. It's on the wall. I think we can do it. We definitely have the need. You've heard it from law enforcement. I had a tour of the jail as part of our annual inspection a couple weeks ago, and if you look at the list of inmates, a lot of them it's substance abuse, and it's a cycle. And I think we can move upstream with this initiative to help with that before they end up there.
And I can relate. I've had personal experience with somebody traveling 5 hours over to Oshkosh. I fully believe in this facility, and hopefully it goes through. We'll take a roll call vote.
Julie Maderas,
Yes.
Lisa Lind,
No.
Sean Anderson,
Yes.
Kathy Leaf,
Yes.
Dave Osnes, Greg Telejohn,
Yes.
Mike Barkalow.
No.
Motion passes. Any other future agenda items that we'd like to discuss in the future?
I have one.
Yes?
The email that came out discussing the subcommittee and the citizen, I think Adam had sent that out. Where are we at with finding a citizen MD or whatever to fill the seat? Is that something that we talk about here?
You're finding a citizen or a doctor representative?
Well, it's a citizen that we would like to be a doctor, is my understanding.
I don't know where we're at with that. I've put out several feelers and had some rejections. Ken, I believe you have too.
Yeah, I don't know that it would necessarily be an agenda item. The county administrator is vested with putting forward a name for that appointment, and I haven't yet.
And you've had interest?
Yeah, there's been, I have a list of people that are interested.
Okay.
Yeah. So I haven't done it yet. So.
Let's do it.
So your county administrator is negligent, but it really wouldn't be anything.
But you look good without
Yeah.
a coat on, so it's good.
Yeah. It really wouldn't be anything that you'd be able to vote on.
Right.
So,
Okay.
point taken, though.
Well, if there's no other future agenda items, go ahead. I'm
Yep.
sorry.
I'd like to bring up the agenda item that was brought up at the county board.
I would like us to take up a audit of current programs, assessing the number of constituents using them and their ongoing costs. Make recommendations back to the board whether we should continue these programs or not.
I would also like that to be on the agenda.
The county fair is on.
Yeah,
Let's go. It starts tomorrow officially. I was there today volunteering, and a lot of people, kids, and it should be exciting, so, and warm. So.
We got that.
If nothing else, I adjourn the meeting at 6:25.